Do I need to start again since I did not have the mic on? Now I can officially, with the mic on, call the Subcommittee on Military Construction, Veterans Affairs, and Related Agencies to order. I'd like to welcome Secretary Wilkie, who is our witness this morning, for joining us. And since this is our first hearing with some members participating remotely, I'd like to begin by offering a brief explanation of how it will work in order to benefit both members and the public. First, this hearing room has been configured to maintain the recommended 6-foot social distancing between members, witnesses, and other individuals in the room necessary to operate the hearing, which we have kept to a minimum. As I mentioned, some members have opted to use secure video teleconferencing, which allows them to participate remotely. For those on video conference, once you start speaking, there will be a slight delay before you are displayed on the main screen, as I am now. To minimize background noise, we ask that the members who are participating virtually remain on mute until it is your turn to ask questions. Please remember to mute yourself at the conclusion of your question. Should you seek additional time, please unmute yourself so that I may recognize you. Just like if you were in the room and you want to get the chair's attention, you would turn your mic on and ask for attention. For those participating remotely, your voice will actually activate your appearing on the screen across the room. So just know that it doesn't go on. You don't move to the screen until you actually begin speaking. I remind all members and witnesses that the 5-minute clock still applies. If there is a technology issue, we will move to the next member until the issue is resolved, and you will retain the balance of your time. For members using the video option, you will notice a clock on the bottom of your screen that will show how much time is remaining. At 1 minute remaining, the clock will turn to yellow. At 30 seconds remaining, I will gently tap the gavel to remind members that their time is almost expired. When your time has expired, the clock will turn red and I will begin to recognize the next member. In terms of the speaking order, we will follow the order set forth in the House rules, beginning with the chair and ranking member. Then members present at the time the hearing is called to order will be recognized in order of seniority. And finally, members not present at the time the hearing is called to order. Today's hearing is on VA's response to the COVID-19 pandemic. Again, we welcome the Department of Veterans Affairs Secretary Robert Wilkie, who is joined by Dr. Paul Lawrence, the Undersecretary for Benefits at the Veterans Benefits Administration, Mr. John Rochalski, the Assistant Secretary for Management and Chief Financial Officer, and Dr. Jennifer McDonald, Chief Consultant to the Deputy Undersecretary for Health. Thank you all for being here today. I cannot underscore enough the importance of this hearing as we strive to take care of our veterans and do everything in our power to keep our frontline healthcare workers safe. This hearing is an important opportunity to provide oversight of the almost $20 billion Congress has appropriated to VA in emergency funding in the Families First Coronavirus Response Act and the CARES Act to assist VA in combating the pandemic. The bulk of the funding we have provided, $14.5 billion, is for direct patient care. And it is our duty to oversee that funding to ensure that VA is administering and veterans are receiving the utmost and highest quality of care, especially during these unprecedented times. With that money, we expect VA to provide enough personal protective equipment, or PPE, to every single person working in a VHA facility and to their patients when necessary. As soon as one COVID-positive patient walks through the door of a VA facility, every VA employee working there is at risk for contracting the virus, whether they are directly treating the patient in the COVID-19 ward or not. I understand the shortage of supplies and unstable supply chain issues contributed to VA's implementation of austerity measures for providing PPE, but only providing PPE to frontline VA healthcare workers, particularly only those who were treating directly COVID-19 patients, was unacceptable, especially given the amount of interaction other VA employees have with patients who may or may not display symptoms of the virus. And we all know and are well aware that you do not have to be symptomatic in order to be carrying the virus. I am glad that VA has started to make steps in the right direction after unrelenting backlash from Congress on the irresponsible PPE policy, and has since updated it to reflect the need to provide one mask for every employee, regardless of direct patient interaction or not. And I appreciated the opportunity, Mr. Secretary, to talk with you throughout this crisis, express our concerns, and also get feedback from you on how we could be helpful to you in making sure that we could right that ship. However, despite this being the policy on paper, I am still hearing concerns at the field level that it is not being implemented consistently, so many veterans and employees are still left unprotected. VA must make sure it is communicating effectively. It is not enough to issue guidance. regarding the health and safety of veterans and VA employees, VA must ensure that such guidance is being adhered to and implemented consistently. Further, VA must do everything in its power to meet conventional CDC standards in PPE usage. Any austerity or contingency measure in place on PPE usage leaves veterans and healthcare workers vulnerable to infection. This is especially egregious when the President has it within his full authority to fix the problem of a lack of supplies and PPE by fully invoking the Defense Production Act so that American businesses can completely fill the gap in the supply chain for these vital resources, which is the Defense Production Act's purpose. VA would no longer have to compete for scarce supplies like it currently does, and VA could revert back to conventional practices rather than austerity measures in administering PPE. Further exacerbating the problem, scarce resources create the ripe conditions for price gouging, which many companies are taking advantage of. A ProPublica piece published a couple of weeks ago shed light on the issue of small, inexperienced contractors charging exorbitant prices for scarce PPE, and VA agreeing to pay that price because of how desperate the situation was. I understand these are unprecedented times, but we need to do everything we can to protect our veterans and our frontline healthcare workers who are putting their lives at risk to combat this deadly virus while still protecting taxpayer dollars to do so. Additionally, within the funding Congress appropriated, we also want to make sure that VA is providing adequate testing to veterans and also to its employees. I cannot stress enough the importance of testing, as it will be the only way we can get a handle on how the virus is spreading and where. We need adequate testing to make Americans feel safe. We do not have a consistent, comprehensive testing policy at VA right now, and that must change. This is especially important as VA makes the decision to reopen its facilities around the country beyond emergency and urgent care. VA has already begun reopening at 20 facilities and plans to reopen additional facilities and start to resume more services in a phased process. We need to make sure that we have sound policies in place so we don't see spikes in the virus as we move forward. Lastly, when veterans are at VA hospitals, we need to make sure they are being treated with the utmost quality of care. More and more information is coming out about how ineffective and potentially deadly the anti-malarial drug hydroxychloroquine is to COVID-positive patients. What is astounding to me is VA is still insisting on providing this drug to veterans, yet VA cannot effectively communicate the circumstances in which the drug is administered. I hope that changes today. We clearly have a lot of ground to cover today. Thank you all for being here this morning, and I look forward to your testimony, Mr. Secretary. At this time, I'd like to yield to my ranking member, Judge Carter, for his opening statement, and please note there may be a delay before he is displayed on the main screen. Judge Carter?
Good morning from Round Rock, Texas. And Chairman, thank you for this hearing today. Just to let you know that right now it's 67 degrees outside in the Lone Star State. Temperature is going to be up around 85 today, which is kind of cool for us. I'm really glad to be here today. I never thought I'd be holding the hearing sitting in my home, telecommunicating. This is quite a step. This hearing is a big step for the Appropriations Committee and the House of Representatives, and a first step, so I'm proud to be part of it. I congratulate Chairwoman Lowy and Ranking Member Granger for their leadership in this, and I'm very proud of our subcommittee chairwoman who has been working very hard to get this done right. And I thank all of them and congratulate them for their work. As a member who cannot attend this hearing in person, I guess this is the best I'm going to be able to do, and I'm grateful for it. This will help us all as we continue with our oversight of the Department of Veterans Affairs, especially its response to COVID-19 and the use of supplemental funding provided just 2 months ago. Secretary Wilkie, thank you for being here to talk with us about the VA's response to COVID-19. In many ways, the VA has been at the forefront of America's response and has been a leader in caring for those affected by the pandemic. VA's quick and decisive actions to protect residents in community living centers and other special care facilities, such as spinal cord injury units, spared many veterans serious injury or illness and possible death. VA has also stepped up a system, and as individual employees, they work to help civilians. It provided an urgent need for doctors, nurses, beds, equipment, and medicine in every corner of the United States. In the past, not many would have believed that a large, decentralized national healthcare system could so quickly and effectively respond, but the VA did, never losing focus on their first mission, which is care for our veterans. The VA has some problems, such as finding and maintaining supplies of personal protective equipment for its employees and questionable contracting procedures, and we'll discuss these issues today. We also need to discuss the supplemental funding provided by the CARES Act and whether there is a need for additional funding in any follow-in or follow-up package that may be coming in future years. In closing, I want to thank the committee's technology staff and the House Recording Studio for their very diligent work. We are holding this hearing today because of your know-how and willingness to help us learn. And I personally thank you. Madam Chair, thank you again for yielding me this time, and I yield back.
Thank you, Judge Carter, and I appreciate your kind words and join you in thanking our appropriations staff as well as the technology staff and House Recording Studio. This is one of the, outside of the Rules Committee, the first with outside witness hearings, outside witness hybrid hearings, where we have some members participating remotely and some in person. And there was lots of dress rehearsals that went into this, and to make sure that everything was going to go smoothly. And I thank all of the members for their cooperation. And that's the spirit of this committee. It always has been, and it's deeply appreciated, so that we can continue to do the work that is so important for us to do. Judge Carter, thank you for your thoughtful remarks. Now I'd like to yield to the full committee chair, Congresswoman Nita Lowey, for her opening remarks. And again, there might be a slight delay before she appears on the screen. Madam Chair, you're recognized.
I thank Chairwoman Wasserman Schultz and Ranking Member Carter for holding this very important hearing. And I welcome Secretary Wilkie and our other distinguished officials. And I thank our committee staff for navigating this new way of conducting business. Before we begin our discussion on the heels of Memorial Day, we would be remiss not to mention our recent calls for the removal of Nazi headstones in some of our cemeteries. Although predecessors may have allowed them, today we need to do the right thing and remove these offensive symbols from the solemn ground where our brave warriors rest. During this horrible corona crisis, our responsibility to the men and women who have served our country has never been more vital. This administration's lack of preparedness and mismanagement has led to needless death and suffering and much fear among veterans, their families, and the healthcare professionals who care for them. To date, there have been more than 13,500 cases of COVID-19 diagnosed throughout VA healthcare facilities. Of the 1,193 tragic deaths, 241 have occurred in New York. The situation, and even more tragic, in state-run veterans' homes, where our most vulnerable veterans have been denied the highest quality of care. The VA has a responsibility to oversee and ensure the facilities are meeting VA standards of care, and VA should have stepped in sooner to help. For nearly 3 months, the VA healthcare workers have risked their lives and the lives of patients because of a shortage of personal protective equipment. The lack of urgency by the VA to address this need has likely contributed to additional sickness and death. I do hope that we are all on the same page and that we can work to fix this issue, which is so outrageous. Veterans have suffered because of disruption to routine physical and mental health care visits. Many face the stress and burden of unemployment, homelessness, and uncertainty. And at a time when veterans most need the VA to be ahead of the curve, it is falling behind. We need to understand what went wrong, why then we can understand and identify what needs to be done to avoid this shameful treatment of veterans in the future. So thank you. I look forward to your statement, and I do look forward to answers to our questions. Thank you.
Thank you, Madam Chair. Appreciate your thoughtful remarks. Mr. Secretary, as always, your full statement will be entered into the record, and you are recognized to summarize your remarks for 5 minutes.
Well, thank you very much, and I want to thank you also for your availability to me throughout this. I value that relationship, and I think it is incredibly important to the department. You know, we are fighting a war that very few people in America would have predicted just a few months ago. Our doctors, nurses, and staff are routinely putting their lives on the line and sacrificing time with their families to care for veterans, most of whom are older and are therefore more vulnerable to this virus. 31 of our staff members have passed away, and as you know, we have lost hundreds of veterans to this disease. But the news is not all grim. From the start, VA took an aggressive posture to protect our patients from COVID-19, and our staff has worked tirelessly to carry it out with great success. Here is where we stand. We have diagnosed 11,500 veterans with the virus, but over 9,000 of them have fully recovered. That is 76%. Today, we are only treating 1,500 veterans for the virus out of the over 9.2 million veterans who are in our system. We are stocked with supplies. On average, VHA has a minimum of 2 weeks supply on hand of each type of PPE: gloves, eye protection, masks, gowns, and sanitizer. We are staffed in part because of the changes that we have made in our hiring processes. In the last 5 weeks, we have hired more than 10,000 medical staff, including 3,000 nurses. And as I discussed with the chair yesterday, I intend to keep these processes in place. If I need to come for a legislative fix, I will be doing so after consultation with you. Our infection rate among VA staff, I can argue, is the lowest of any healthcare system in the country. It is either at 0.5% or lower. And I credit the steps that we took early on to protect those on the front lines with these incredibly low numbers. We were the first healthcare system and the first federal agency to activate our emergency procedures. We did so in January, establishing 19 emergency operations centers across the country. We did begin to manage our supplies of PPE, and as I've been candid with the chair, our regular supply chain was disrupted by this national emergency, and we have changed to meet that emergency. In some ways, we have stressed the system, which I think will be better for the future. Telehealth services have expanded exponentially. In a normal month, we would conduct 40,000 mental health televisits. We are now at 900,000. We are reaching areas of the country that we never thought we would reach, particularly in tribal and rural America. This is a game changer, particularly when it comes to mental health. In April, we began working our fourth mission in earnest, taking in non-veterans in hotspots and deploying VA staff to nursing homes and state veterans' homes that needed our expertise, an issue I know some of you will want to talk about today. In addition, our Veterans Benefits Administration has reached out to more than 400,000 veterans and continuing to talk about our response and answer questions about their benefits during the crisis. Our National Cemetery Administration has taken steps to ensure that loved ones are interred in
Yeah, there isn't a decent question there because he answered them, but I'll just think it's...
Madam Chair, you need to mute your line. Secretary, you can resume.
That our veterans are interred in a...
Mr. Secretary, you can proceed. I'm just going to make sure we have technical
go
issue.
ahead?
Please proceed.
I'll just divert to, I was privileged to address several veterans at the Quantico National Cemetery on Memorial Day, and as I was looking out down the hill, I saw veterans' families gathering on that day to pay their respects to their loved ones. Our veterans' cemeteries have never closed. Our hospitals have never closed. At the end, I believe that our people have turned VA into a learning organization that was able to turn on a dime in this crisis and transform itself from an institution that many of us have known and some of us have looked askance at for many years. I can't thank them enough for their agility. I can't thank them enough for putting themselves in harm's way to serve their fellow Americans, and I thank you, Madam Chair, for allowing me to speak.
Thank you, Mr. Secretary. Now I'd like to begin my 5 minutes of questions. Mr. Secretary, I want to start off this hearing discussing the issue of personal protective equipment, or PPE, which I noted has been a huge issue for the VA. As of yesterday, VA has about a 39-day supply of gloves, a 333-day supply of face shields, a 267-day supply of N95 masks, 244-day supply of generic and surgical masks, and about a 50-day supply of gowns. This is a significant improvement from VA's earlier days in combating the coronavirus pandemic, when it had 18 days or less of all supplies, leading to VA evoking austerity measures on VHA employees' use of PPE. Per CDC guidance, as PPE availability returns to normal, healthcare facilities should promptly resume standard practices. Now that VA has significantly higher amounts of PPE, does VA plan to issue any additional, less stringent guidance to the field to further protect veterans and healthcare workers? And would you please clarify for the record what VA's guidance is regarding who receives PPE and under what circumstances they receive it, including veterans, frontline healthcare workers, and all other employees in the VA facilities?
Yeah. I'll let the practitioner give you the chapter and verse on what the medical needs are. I will say that our hospitals have never run out of equipment. But in response to this emergency, as you and I discussed yesterday, we are putting in place plans and operations so that we do not have to adjust to a disruption in the supply chain. I have given instructions to begin the establishment of depots across the country to supply, to house PPE and other medical equipment so that if this does rebound.
Mr. Secretary, I want to be mindful of my time constraint. Yeah. Specifically, with more availability of PPE, do you have plans, because the last time you reissued guidance was May 1st, do you have plans to issue any additional, less stringent guidance to the field so we can further protect veterans and healthcare workers?
We will as we resume normal operations.
How many days' worth of supplies will VA need to have on hand before you're comfortable to further reduce the austerity measures?
Madam Chair, I thank you for your attention to this issue, and I just want to emphasize that our workforce is our strongest asset. We have a workforce that runs toward a challenge, and it is our utmost priority to ensure that they are safe.
I apologize. My time is limited, and we'll stipulate that we all very much appreciate their work.
Yes, ma'am. And we have moved to universal masking throughout the pandemic. I'm proud to say that because of our early planning that began in January, our workforce has had what they need throughout the entirety of the response. Those on the front lines have N95 masks. Those in facilities have a mask a day. And every visitor to our facility, even if they are the caregiver of a veteran accompanying that veteran to a critical appointment.
Right. But I'm specifically asking about the austerity measures. Because yes, I understand that they're issued masks, but the concerns that have been expressed, the whistleblower anonymous complaints I've been getting have indicated that they're required to reuse repeatedly those masks, to have them lay out in the sun in order to sanitize them. What are the current criteria in terms of a mask issuance and PPE issuance so that that reuse policy is not required?
Madam Chair, thank you. We are at universal masking right now, and in reference to the austerity measures, this was a move in line with CDC guidance at the beginning of April. As the global supply chain was in a state of uncertainty and as the virus was surging, we were certain that we had 2 weeks of supply on hand. What we weren't certain of was our ability to resupply. And we made a strategic decision for a very brief period of time to make sure that our supplies would reach until we could be resupplied. At each point and each day across that time, our employees had what they needed and had N95s and masks and the full set of personal protective equipment that they needed to care for patients.
And I would add, right now, we sadly have about 500 employees who are infected. The reason that number is stark is that that's 500 out of, in VHA, 330,000. So the measures that we put in place, arguably emergency measures, were designed in an emergency to take care of those who are the most immediately vulnerable. I've been able to expand the use of PPE as the emergency has changed. But I would also argue that the entire nation has been learning this on the fly. And as you and I have discussed, for the first time in the history of VA, we did have to share resources with the City of New York, the State of New York, the City of Los Angeles. We followed CDC guidelines. We followed them to the letter. We followed the same guidelines that you would find at Georgetown or Medical Center or in NYU. And I think the results have shown that we have done an excellent job, better than any healthcare system in the country, in keeping these numbers as low as we have.
Okay, I'm sure that other members will get into the PPE issue further. With the committee's indulgence, I'm going to ask an additional question, and we'll, certainly recognize Judge Carter for longer than 5 minutes. But I do want to take a moment to enter the following into the record: a letter from myself, Judge Carter, from Chairwoman Lowy and Ranking Member Granger of the Full Appropriations Committee to you, Secretary Wilkie, regarding the gravestones that have been discovered that are at the Sam Houston VA Cemetery in Houston, and a VA cemetery in Utah as well, that have the Nazi swastika as well as inscriptions honoring Hitler on them. So I'll ask unanimous consent to enter all of the following into the record. A statement from the Southern Poverty Law Center that urges you to recognize the offensive nature of those inscriptions and statements and to remove them. A statement from B'nai B'rith International that also asks you to remove those gravestones and the inscriptions and replace them with more appropriate information about the deceased. A statement from the ADL via their social media, the Anti-Defamation League, asking the same, and a statement from the American Jewish Committee asking for the same. This is deeply troubling to learn that several VA cemeteries contain graves of German prisoners of war that feature swastikas engraved on the headstones, as well as inscriptions that honor Adolf Hitler. These graves sit right alongside men and women who fought for our country and our ideals that run counter to everything the swastika and the Nazi ideology represent. And I understand that these cemeteries were not under the jurisdiction of VA at the time these headstones were installed, but now that they are under VA's jurisdiction, there is no excuse for VA to continue to maintain these headstones instead of replacing them. The agency has claimed in its public response on this issue that You won't replace these headstones because the National Historic Preservation Act of 1966 requires federal agencies to protect, quote, historic resources. In fact, what the Historic Preservation Act refers to as historic resources are defined as sites worthy of inclusion on the National Register of Historic Places. And in case you were wondering, the National Register criteria generally does not consider individual grave sites eligible, except in case of, quote, historical figures of outstanding importance. Certainly German soldiers who took up arms against the United States do not meet this criterion. It appears that this is relying on a gross misreading of a law that was enacted to preserve and protect historic sites and neighborhoods so that we did not erase our nation's history in the name of development. It is not a blanket excuse to avoid addressing past mistakes. So, Mr. Secretary, I really fail to understand why thus far you have refused to remove and replace these gravestones with Nazi insignia. Is that the kind of stewardship that contributes to the, quote, inspiration and benefit of present and future generations as the law actually states? And if it's not, as you and I both know it's not, then how can you continue to claim that the VA is unable to replace these headstones simply because of historic preservation law?
Well, Madam Chair, I'm going to, if you don't mind, I want to take a moment of personal privilege on this.
Sure.
You and I, in the last 2 years of our relationship, I have exchanged speeches with you that I have given in Israel, that I have given to the Jewish war veterans. In fact, I made a point that my very first speech at VA was with the Jewish war veterans. And as you know, my son, in his senior year in high school, spent that year working at the Holocaust Museum. This is a subject, the oldest hatred, which I am very passionate about. If you go to Yad Vashem, the words mean of memory and a name. Anti-Semitism is rearing its head all over Europe as we speak, and we've even seen it in some places in the country. I happen to agree with the president of Haifa University, who was quoted in that Wall Street Journal article that the last thing we need to do is not remind Americans of the horrors of anti-Semitism and the horrors of the Nazi cult. I have asked my people to look at various ways to address this. I happen to think that making sure that when people visit our cemeteries, they are educated and informed of the horror is an incredibly important thing to do. Erasing these headstones removes them from memory. And as we continue to study the Holocaust, the last thing any Holocaust scholar wants to do is erase that memory. I think we can find a way to put this in historical context. That is my view, that we cannot erase the horror and ignore it. We have to continue to hammer it. My view is that we need to look at historical interpretations that I am very happy to put up. And I would also note in that Historical Preservation Act in Section 106, these cemeteries which we inherited from the Army are on the National Register of Historic Places.
Mr. Secretary.
I would have to engage in a very long process right now in order to erase.
No, Mr. Secretary, if you look closer at the wording of that statute that VA is, that you just cited, Section 106, that you're apparently hiding behind, it says that it's the policy of the federal government to, quote, administer federally owned, administered, or controlled historic property in a spirit of stewardship. A spirit of stewardship does not restrict VA from taking a serious look at the purpose these headstones once served and whether they are appropriate today in their current form. In fact, VA's own materials on this issue acknowledge that the law does not prevent you from removing them. The law merely sets forth the consultation process for taking action. VA could begin that Section 106 process, as it's known and as you just referred to right now, and start the process of removing these headstones. VA also clearly acknowledges that engravings on headstones can send messages about our values. For example, on VA's own website discussing the various emblems of belief that can be engraved, it says, quote, VA will not inscribe any emblem on a headstone or marker that would have an adverse impact on the dignity and solemnity of cemeteries honoring those who served the nation. I would argue that swastikas, as well as the inscription that these headstones feature, honoring Hitler, absolutely have an adverse impact in honoring those who served. We do not erase history by replacing these headstones for modern times with more appropriate inscriptions, and I am certainly not suggesting removing the dead who lie beneath the headstones, but I urge you to immediately begin the Section 106 process to replace these inappropriate and insensitive headstones. There are far more individuals across the world that think that that is absolutely essential when we look through the lens of modern times. And I hope you're not suggesting that replacing these few offensive headstones with neutral replacements done in a respectful way would be an unreasonable step to take in the name of sensitivity. You have soldiers who fought and died, who were killed by the Nazis, whom they are lying next to, and whose loved ones need to walk past inscriptions in American veteran cemeteries that honor Hitler and have a Nazi swastika. The Nazi swastika is prohibited in Germany from being displayed because it is not seen as a reminder to prevent the hatred that it spawned. It is seen as something to be snuffed out. And there are certainly ways that you can put the gravestones in an appropriate historical context that don't lie above the graves of these dead. So I've taken far too...
Let me
Yes.
let me respond.
I hope that I urge you
Yeah.
and ask that you begin the Section 106 process, and will you do that?
And I will certainly, I will review everything. I'll just finish with a statement that was issued in 2018 by the American Council on Historic Preservation, which governs these matters. It is essential for decision makers to directly confront history's difficult chapters, consult broadly with the public to ascertain contemporary community views, and consider a range of management alternatives to promote public education regarding all aspects, positive and negative, of the nation's history. What I am just saying is that as someone who cares deeply about this, and you know I do.
I do.
I do want to do it in a way that still reminds Americans of the horror. And because of the times in which we live, where we have seen anti-Semitism reach our shores, I want to make sure that VA is doing the best that we can to educate and remind people why those veterans in that cemetery fought against that horror from 1941 to 1945. So I just want my meaning clear about what I'm thinking.
Mr. Secretary, I don't want to prolong this, and I certainly am not questioning your personal commitment to upholding religious pluralism and fighting against anti-Semitism. But a review is not a commitment to begin the Section 106 process. And I can assure you that this is not the last time we're going to deal with this. This is going to be dealt with one way or the other. So I really would urge you to make sure that we can set aside those gravestones from the 1940s and put them in context historically. There are other places in these cemeteries to do that without having them appear.
And that may be the,
reclaiming my time.
yeah, and that may be the answer.
Reclaiming my time, Mr. Secretary, without having them appear above the graves of the Nazi POWs and having our families of those soldiers that were killed by Nazis walk past them when they visit their loved ones.
And I will conclude by saying I don't think we're that far off, because I do think that putting those in context in the cemeteries, as you just mentioned, is the way forward. It's just I'll take a look and see what we can do, because we have the same goal in mind, and as you know,
appreciate that.
I'm very passionate about that issue.
Thank you. I am as well, as you can see, and I hope we reach the same conclusion, is that they are not in appropriate context now. Thank you very much for the committee's indulgence. I apologize. And Judge Carter, you're recognized for your for as long as you want to, basically. Thank you very much for the committee's indulgence. Judge Carter, you're recognized.
Thank you, Madam Chairman. Thank you for recognizing me. And Secretary Wilkie, welcome. Glad to have you here. I before I go to some of the parts of the questioning here, let's go back to the subject matter at hand. I love history, and I read history, and I read, my hobby is reading history. In trying to consider what probably happened in 1943 and 1944 when these things were erected, it's hard to conceive in the 21st century why they would be that way, with all we know about the horrors of what went on to the Jewish people and other people in those concentration camps. But if you will study your history, you realize that we had rumors of these things at the governmental level. But they weren't subject to 24-hour news like we do. And yet, so the average American or the average soldier, he may not even have a concept of what was going on in the persecution world of Germany at that time. And even if you hear comments about how the attitudes changed after we actually discovered the concentration camps, and our soldiers became even more vehement in their battle when they realized the horror that they were fighting against. And so maybe the people that erected these stones didn't realize what historically that would be, how much it would affect the Jewish people and Americans who are all horrified by what went on in Germany at that time. So I think that you should replace these stones with just a regular stone and still say they were German prisoner of war, but that's it. And take all the Nazi symbolism off. And if somebody wants to preserve those tombstones for history's purpose, then the Historical Commission can preserve them in some other way. But I don't think that should be displayed daily to the American public because of what now that we know what happened and are aware of it, we are offended by things like that. So, taking it in context, I think we should definitely do it, and I think it's the right thing to do as Americans.
Well, yes, sir. And I think
if you want to comment back, I'd be glad to hear from you.
Yeah, we're in the same place. And I mentioned earlier, my only concern, and it's one from a passionate view, is to make sure that when we do this, we are still reminding people of that horror and why those soldiers fought, and that we educate, because the last thing, there's a museum down the street that will not let people forget. It is to never forget. And because of my feelings on this issue, I want to make sure that if it's done so that we still allow people to reflect, to contemplate, and to say also never again.
Well, I sure hope we can work this out because it's very important to every member of this committee, the Appropriations Committee. You'll note that both the chairman and ranking member of the full committee have endorsed our letter, and we expect it to be done. Moving on, the CARES Act provides you with $19.6 billion to respond to the COVID-19. As of last week, less than $2 billion of that money has been obligated. How much funding has been obligated as of today? How much has been allocated? And should we be concerned about the low rate of obligation?
I'll let John Rachowski, our Chief Financial Officer, answer that. Madam Chair, is that all right?
Yes, but before he answers, there is one vote that begins now, but we're voting in those groups. So I'm going to continue with the hearing, and members who have to go vote during their group should do so, and then just come back to the hearing. So yes, Mr. Michalski, you're recognized.
Thank you, and thank you for the question. So as of today, I would say about $2.3 billion has been obligated. And should we be concerned about that, or does it seem low? What I would say is we don't really have a precedent to compare. We're sort of creating the baseline today. We are finding many things out. At first, I think the committee for the funds they provided, there were some expenses that were less, some were more. For example, we were putting some workers into hotels so they didn't have to go home, things like that. And so we're going to know a lot more in 6 months. I think that we are absolutely adequately funded at this time. The one thing I would say that we probably can make better use of this with some additional flexibility, and by that, I mean maybe some additional limited transfer authority. There were a couple of areas where we probably did not think through what we needed. VBA for overtime and some education system upgrades, NCA for additional workload. But I think we're providing updated obligation reports weekly, and we're going to see how this goes. It's just, there's nothing really to compare it to know if that's low or high. In some cases, as you know, the materials and supplies weren't available when we wanted to buy them. We also have to go through the federal procurement process pretty much, and that takes a little bit of time. We have an old accounting system, so not everything is real time. But I think that we'll see this grow pretty substantially, especially as we resupply ourselves and have stock on hand.
Judge Carter?
Well, the administration is considering a fifth supplemental funding package as needed. How much more do you think the VA, how much would you estimate the VA would need an additional supplemental package if we put one forward? How much more does VA estimate will be the need to address current COVID situation? What if the infections spike in the fall, as some are predicting? And if you were on this subcommittee, how would you balance the low obligation rate for the CARES Act funding with your estimate of future needs?
Thank you, sir. So I think that with respect to additional supplemental funding, I think from what I see now, we're adequately funded. I don't know what's going to happen in the future with respect to spikes and things like that, but I think we're still, from a medical perspective, adequately funded. For additional needs, so not in their area. The one area I could see potentially additional needs, and we're working with our facilities folks to see about accelerating reconfiguration of some of our facilities from multi-patient rooms to single-patient rooms. That was something that we already knew, but can we accelerate that? That made a big difference. But that's probably the only area. If I was on the committee, I'll tell you what, we need more than money at this point is probably some additional flexibility that I mentioned to move some of the CARES money around. And then some additional legislative, I think, provisions. We have one that's very important right now, and it's sort of related, but not exactly. We need authority to keep paying our community care bills the way we are today. We call that obligate and pay. We have a legal ruling that we are probably not in compliance with the law, with the procurement law. If we don't get that authorization, we are going to be short about $5 billion in community care. But it's a matter of an accounting issue and a legal issue as opposed to a money issue.
Judge
Thank you,
Carter.
Madam Chairman. I'll yield back.
Thank you so much. Judge Carter yields back. Next, I'd like to recognize Chairwoman Lowy for her questions. I don't see Chairwoman Lowy on video. Is she still with us? Okay. Chairwoman Lowy, your video is turned off. Okay, we'll come back to the chairwoman, and Mr. Bishop and Mr. Case have gone to vote. So Ms. Pingree, you're recognized for 5 minutes for your questions.
Thank you, Madam Chair. Thank you, Secretary Wilkie, for being with us here today, and for the work you're doing to take care of our veterans. Thank you to all of your staff, who we know are extremely dedicated to our veterans and are challenged every day working in the healthcare field. And also our hearts go out to the family of those veterans who have lost their lives to COVID-19. I'm going to take a little bit of a different tack, but I know we're talking about all the issues related to the situations that people are struggling with COVID-19, and one of them is around food insecurity. There's such a long-standing food insecurity crisis among our veteran population. Over a quarter of Iraq and Afghanistan war veterans have struggled to put food on the table, which is about double the national rate. It's also related to adverse health outcomes, which we know are an indicator for those people who are really struggling with this particular disease. And we know that food insecurity is exacerbated during this crisis. We've all seen the long lines at food banks and the challenges that many families are facing, and our veterans are particularly vulnerable. As I said, the pandemic has also put an extreme burden on some of these disadvantaged populations, including those with underlying health conditions. Data shows that veterans have higher rates of multiple chronic disease-related conditions like heart disease, hypertension, and diabetes. So my concerns are around both, are we assessing food insecurity with our veterans, and are we improving access to healthy food? It's much more of a long-term problem. So one of the challenges that we've seen during the COVID-19 crisis is it shows us some of the underlying issues that people are facing, whether it's around the underlying health conditions or just basically getting food at any moment in time, but today in particular. So can you give us a little update about how the VA is tracking food insecurity during this pandemic? And also, do you have data right now on the burden of obesity and chronic diet-related diseases within the veterans community?
Well, thank you. I'm going to answer the first part by saying that the chair of the subcommittee actually answered our most immediate food security need. In your emergency package, you upped the amount of money for per diem costs, which we have instructed those receiving them to use for, amongst other things, their food. And that, I think, has helped more people than you probably knew when you entered into that. So I thank the chair and I thank the committee for that. I'll give you a statistic. In my parents' hometown of New Orleans, of those who passed with the virus, 51% had diabetes. We have an aggressive education and outreach program on food and on health related to food choices. And I'll let Dr. McDonald go into the particulars, but this is the subcommittee that recognized that problem, and we've certainly made up ground, particularly in the homeless community, on this.
Congresswoman, to follow on to what the Secretary said, one of the silver linings in this extremely challenging time is the nation's emphasis on population health, and certainly that is our priority within VA. I thank you for pointing out this issue that the social factors affecting veterans, including food insecurity, and as we often focus on homelessness, are factors in their health. Chronic conditions are part of it, but where they live, how they live, is a huge part of their ability to succeed in combating this virus and succeed across this time. I'm proud to say that of the first $1 billion in medical funding that you've graciously given us in the CARES Act, more than 20% of that, $205 million, has gone toward our homeless veterans and toward programs that help outreach to veterans and make sure that their food insecurity issues, that housing, rapid rehousing for them and their families are addressed. And I thank you also for calling attention to diabetes and chronic conditions specifically. It is important that we are engaging through our care teams in outreach to all of those patients we know are vulnerable. We are taking specific action to protect those populations that we know are significantly affected or at higher risk of COVID-19. As one example, we have conducted outreach to those veterans who have registered with us as being affected by burn pits. I'm actually one and received the text message myself. I know that this outreach is occurring as I myself am receiving it. And that outreach is important as we engage veterans and let them know that VA is here for them across this time, not just for medical conditions, but for the entirety and holistic approach to their life.
Well, thank you both for your answers. It would be great in the future to see a little more data and certainly to see more of an update once all the funding that has been allocated has been spent. And I do particularly appreciate your comments around our homeless vets. It breaks everyone's heart to think of anyone who served their country living on the streets or going hungry. And particularly in these times, people who are homeless are some of the most vulnerable with this disease raging in our community. So thank you, and I yield back, Madam Chair.
Thank you, Ms. Pingree. Mr. Hurd, you're recognized for 5 minutes.
Chairwoman, first and foremost, I want to associate myself with Chairwoman Lowry's initial comments about the Nazi symbolism in some of our most hallowed grounds and the need to remove that. And I appreciate the chairwoman of our subcommittee leading the charge on seeing that happen. And also, to the leadership of the committee and the staff, I feel like we've been doing more conversations now since COVID-19 than we were before, and I think that shows the commitment to the American people. Secretary Wilkie, it's always a pleasure to be with you. And one of the things I would like to highlight, the South Texas Veterans Healthcare System based out of San Antonio, my hometown. You know, they didn't experience a shortage of PPE that our private sector colleagues saw or academic affiliates saw. They even went as far as help donate, PPE to folks within the community to make sure the community was in response. And they've also been leading in the Video Connect system that was already in use before COVID-19, and they're now a leader in the number of VA Video Connect episodes of care. And one of my questions is, how do we ensure that for the foreseeable future that we're able to continue this level of technical technical support to our activities? Do we have the facilities that and the spaces that where you can have the exam rooms to do some of this telemedicine and telecare? And how are we going to make sure existing facilities are able to deal with this and those not outrageous, but amazing numbers you said at the beginning of your remarks, Secretary Wilkie?
Well, thank you, sir. And the people at Audie Murphy are wonderful. And, Texas is a place where you don't have to explain military service to anyone. I'll just give you a couple of statistics that I gave at the beginning. In April, VHA provided 1.2 million mental health, telephone, and televideo visits. And that is an astounding number. We have stressed the system, and I don't believe we're going to go back. Part of the change has been the distribution of thousands and thousands of tablets, particularly in rural and Native America. I cut the ribbon on the first of VA private sector telehealth clinic at a Walmart in Asheboro, North Carolina. I expect Walmart will be expanding that across the country, particularly as Walmart has a footprint in most of rural America. Video telemedicine is the wave of the future, particularly in mental health. And I think we are now at a stage where we're not going to revert back to the old ways. The subcommittee has recognized that by funding our outreach, and I'll ask the practitioner if she has anything to say, Dr. McDonald.
Thank you, Mr. Secretary. I will simply add that as part of the way we design facilities, even now, telehealth is included in those plans. And the beauty of the authority that you all have given us with the option to provide telehealth anywhere to anywhere, where a veteran is able to be at home in their living room, and our practitioners are able to deliver that care from anywhere they may be serving. That gives us the flexibility to use space and optimize space for the in-person care that's necessary, have the telehealth facilities as are needed in our VA medical centers, but deliver most of this care direct to a veteran's living room and meet them where they are and keep them safe in this time. So thank you for your attention to this.
No, and we'll keep focus on this. A colleague of mine, Representative Herrera Butler, and I had been talking about the issue of sepsis. Sepsis is something that's already a leading cause of death within VA facilities, and we know COVID patients are susceptible. I know 10 VA centers are already using a new, more accurate sepsis testing system, and this is even more important than ever. How are we expanding that across our systems?
Sir, as I'm sure you are aware, sepsis is a complex constellation of symptoms, I should say. There have been several definitions of this over the past 20 years. And what it takes is recognizing clinically what we call gestalt, looking at the numbers of a patient, also observing how sick is this person and identifying this early so that you can act. You can hydrate the person, you can get them the antibiotics they need. What several of our facilities, as you've referenced, are exploring is an automated way to synchronize that data and alert clinicians that this might be sepsis, then for them to make a more immediate clinical decision to engage that patient. We already have extensive and consistent protocols across our system for this, and we have excellent data to show that we're effective in managing this. But these advancements in technology may take us one step further, and that, as you mentioned, will be important in this setting of COVID, where we know that this is a complication of the illness.
Thank you, Chairwoman.
Thank you, Mr. Hurd. Now I'd like to recognize Mr. Cartwright. Oh, forgive me. I'm sorry. Mr. Case is back. Recognize Mr. Case for 5 minutes.
Thank you. Thank you, Madam Chair. Mr. Secretary, greetings from the Pacific, where you're remembered fondly for being the first VA Secretary to visit some of our more remote VA communities, much less any ranking federal official. And so thank you for not only trying to understand, but trying to feel that remoteness that the veterans feel. I wanted to follow up on and by the way, I want to commend your team in Hawaii and throughout the Pacific. They've really done a really nice job through COVID-19, not only in taking care of our veterans communities, but also in interacting with our local healthcare facilities and providers. It's really, I
Sir,
think,
may I also mention that you're getting a new director?
Pardon?
Admiral Robinson, the former Surgeon General of the Navy, will be coming out in the next few weeks, and he is an outstanding public servant.
Oh, excellent. So we appreciate that very much. I think it's a good model of interaction with the civilian community in the Hawaii and the Pacific, where we really have an interreliance. And along those lines, my question goes back to testing and PPE. I think the question that I have, and this comes from my discussions with some of your team out there, of course, Hawaii and the Pacific, from a public health perspective, have done better than much of the rest of the country. That's come at the expense of our economy, by the way, because we shut down tourism to get those low numbers. So we have a tremendous economic issue where we're one of the worst in the country. From the testing side of it, the concern is that while we were doing a pretty good job on the public health side, the testing and PPE were allocated elsewhere in the country to include, as I understand it at least, the VA community, so that it was really considered as an integral part, really, of that broader community as scarce supplies were allocated. And of course, the concern there has always been that if we did see a surge, or if there came a time where, because we recovered tourism and started to see larger numbers of cases, and as our military started to move around a little bit more, we have one of the largest military communities in the country and largest veterans communities in the country, we would see that surge, and we would start to detect a greater concern over the scarcity of test kits and PPE. And so the question, and this also interacts with the civilian community side, where you really see a little bit of a patchwork in terms of how the non-veterans healthcare community, which the veterans community utilizes for the delivery of services in Hawaii more than many of our other places in our country, that they have inconsistent rules in terms of the use of testing. Some, for example, require all testing to come into any kind of a procedure. Some take a little bit more of a nuanced approach to that. But the bottom line is that that's using testing and PPE, which then gets into scarce supply throughout the entire system. And so I think my question has to do with what is the ability of the Veterans Administration to deliver test kits and supplies, or to assure testing and PPE to its facilities in Hawaii and the Pacific, especially if we do see a surge. Do you have an independent source? Do you have a way of assuring that you're doing that in a surge capacity, regardless of kind of what the rest of our community is doing?
Sir, yes. We are proud to say that due to early engagement with multiple different vendors and proactive planning, we do have an adequate testing supply at this point. 145 of our facilities have rapid testing, and many of those facilities actually have multiple types available of testing, both rapid and typical antigen testing that returns in about 2 days. We are able to cross-level supplies of testing across the country, and we proactively work on pieces that are more challenging in the global supply chain, including nasal swabs and the transport media that is necessary to move the specimens to the test site. We also have a hub and spoke model, as I'm sure you're aware in your area, that helps us more rapidly process those tests and make sure that results are delivered to facilities and clinicians so they can make decisions as soon as possible and keep that care going for patients.
Okay, thank you very much. And Mr. Secretary, I'd be remiss if I didn't use this opportunity to again emphasize to you the importance of the Aloha project in Hawaii, which is our advanced leeward outpatient healthcare access VA multi-specialty CBOC. That has been a 3-year, too long project, 3 years and fully funded, ready to go. I've had this discussion with you and with other VA folks, both in hearings and offline. It's still hung up, and it seems to be hung up somewhere above VA in GSA and OMB. The issue seems to be OMB's inability to understand that in Hawaii we do have higher healthcare costs. Higher land costs, and therefore that has to be taken into account in terms of the lease award. The fact that Hawaii does tend to have higher land lease costs should not disadvantage our veterans. This is a desperately needed facility. And I would put it in the COVID-19 context as well, because it was needed before COVID-19, but it's definitely needed after, and it's definitely part of overall economic regeneration for Hawaii, which, as I said, is one of the most devastated economically. It seems to be that it's on its last few months, but that's what we said last year. So I would really ask for your personal attention to getting this over the finish line, getting that lease awarded so we can, cut through whatever's going on between GSA and OMB and VA and make the award and get this project underway.
I agree with you, sir. And I've said that in a country like this, particularly with the veterans population that we have, one size doesn't fit all. The solution in Fayetteville, North Carolina does not make any sense on the Big Island. So they've heard me. I will go back to them and see if I can, as you say, push it across the finish line. But I agree with you, and I also agree with you about the particular needs of the veterans community on the islands.
Thank you very much.
Thank you, Mr. Case. Mr. Rutherford?
Thank you, Madam Chair. Mr. Secretary, first on behalf of the 1.6 million veterans in my state of Florida, our home state of Florida, I want to say thank you for the service. And I want to talk about access to care a little bit here. One of the, you mentioned that since the COVID-19, we've seen 900,000 telemedicine encounters, and quite frankly, I'm a little concerned about that, because I hear people talk about telemedicine as medicine that's good enough, and in fact, I had an individual that spoke to me about his yearly physical, retired veteran who in the past would get the blood work up and would go in and the doctor would go over those results with him. And this year his physical was a 5-minute phone call, no blood work, because he was in a low-risk population. But the whole purpose, and this goes to the underlying health concerns that have been highlighted, as you mentioned earlier, by COVID-19, the focus on health and finding issues before they become serious issues, that's what that physical is for. So my question is, can you tell me, first of all, define for me what a telemedicine encounter is, because in the private world, I think it's going to be even more concerning, because whether it's CMS paying for that or insurance companies, exactly what is the definition of that? A 5-minute phone call is that a telemedicine encounter? And so how do you find that? Are there areas where you think it's not effective? See, I would think if we're going to have a phone conversation for a doctor to simply go over blood work with me, to tell me where I'm high, where I'm low, what may need to be followed, I think that is reasonable. But for a physical to devolve into just a 5-minute phone call, I question whether that's the best use of telemedicine.
I'll answer what has happened in the last 3 months, and then I'll let Dr. McDonald, the practitioner, give you the details. We were the first healthcare system in the country to stop routine visits. We had to do that. As the chair has pointed out on numerous occasions, not only in this setting but in phone calls, I was making sure that we were preserving our people and preserving our equipment. So those routine visits did stop in terms of face-to-face, but we made up for that in telemedicine encounters. We had to do that to protect patients and to protect our staff. I would say the wave of the future for telemedicine is not in what you just described, it's really in mental health. It is allowing people to address these deep issues in the comforts of their home, or they can visit the library or wherever they feel comfortable to talk to our mental health professionals. That's where we've seen the biggest explosion. And I'll let Dr. McDonald answer the rest of the question.
Congressman, to emphasize what the Secretary said, you're right that there is care that belongs in person. And that high touch, that meaning of the patient and provider relationship, direct person to person, the privilege of that encounter is frankly why I went into medicine. And that is important to us. And to the Secretary's point, that can actually be delivered effectively via telemedicine. To your question about physicals, we are actually going above and beyond and conducting outreach to veterans, meeting them where they are, not causing them to wait for a physical anymore, but making sure that we know their concerns in advance. We're now emphasizing the ability to do that through a phone call, to coach them through the click of a simple link to spin up a video, and conduct that visit in a more frequent, high-touch way that meets their concerns before they have to wait for that annual visit. To the question of the 5-minute encounter, I would offer that sometimes that's the right answer for the person, but via telehealth, we can still have that meaningful, deep discussion and spend the time that's necessary to address their concerns, and that's how we're approaching it. We train our staff extensively on that so that there's really meaning on both sides of that virtual encounter.
If I could ask one last question, this deals with access. In 2016...
Quickly, Mr. Rutherford.
Pardon me?
Quickly, if you can.
Very quickly.
To recognize.
In 2016, the VA authorized 3 of the 4 advanced practicing nursing fields to go to full practice authority, but you did not include the certified registered nurse anesthetist in that. And the argument was that there was adequate access. But I'm hearing that there is a lot of access being delayed because the CRNAs are not available. So can you address that? And is there any consideration to giving them full practice authority?
Madam Chair, may I?
Yes, Mr. Secretary, you're recognized to respond.
The CRNA program was done carefully. We provided our CRNAs with full practice authority in those states where the states had offered full practice authority. I believe we've only hired 18 additional CRNAs But those were the parameters of the practice, and we did that because we needed so many hands on deck for the emergency rooms and the COVID wards.
Yes, Congressman, we are finding that COVID-19 patients, as I'm sure you've heard from your constituents, are difficult patients to ventilate at times. This can take up to 90 minutes of a very skilled, experienced intensivist time. VA has long been a leader in team-based care and team-based anesthesia care, and CRNAs have long been vital members of those teams. We've moved in alignment with industry in this pandemic to make sure that they have full practice authority in those states where that is already occurring. To the Secretary's earlier point, that also gives us a better ability to recruit and retain those essential providers for our teams. We have seen a response rate to offers for RNs at 80% of those offers we extend. For CRNAs, before we extended that full practice authority in those states, it was only 8.7%. We need these members of our teams, and we need that level of agility to respond effectively and deliver the access that you mentioned originally.
Thank you. And I yield back. Thank you, Madam Chair.
Thank you, Mr. Rutherford. You're welcome. I believe Chairwoman Lowy has returned, although I saw her for a moment and now I do not. Okay, Chairwoman Lowy, you're recognized for 5 minutes.
Well, thank you very much. First, Madam Chair, I want to thank you for your comments at the very beginning of the question period. Those symbols on the tombstones go right to the heart of many people who visit, and I thank you very, very much. And I want to thank the Secretary for your thoughtful presentation. I do want to follow up with a couple of the questions. First of all, I want to get an understanding from you what's happening with the hydroxychloroquine. I am concerned that the VA administered hydroxychloroquine, which was unproven for treatment of COVID-19, to more than 1,300 veterans, despite a lack of evidence of its effectiveness. We know now that patients who are prescribed this drug were more likely to die than those who received standard treatment. What was the rationale for administering this drug to vulnerable veterans? And were they fully aware of the risk before receiving it? Has the President's reckless endorsement led to an increase in veterans requesting the drug? Can you explain to me what is happening?
Well, let me talk about this period of time that we're in. This is a new disease. And even though I am not a medical person, I'm a military person, I understand that there has to be hope. You can't look at a patient and say, we can't give you hope. What I relied on was the vote of this Congress, the right to try. The right to try that was endorsed by the President with his signature. This Congress was very clear in saying that if people of sound mind ask to be given experimental treatments because that may be the last thing that separates them from life and death, that we do that. The other option was to do nothing. Everyone is learning in this in real time, and we have followed FDA guidelines on this. Now we have, I think I gave the chair a chart. We have brought down the use of this. It peaked when it peaked in the rest of the country sometime in April.
Let me just ask you to pause, and I'll ask unanimous consent to enter the chart that is labeled hydroxychloroquine timeline and utilization into the record.
Right. The use of this, Madam Chair, peaked when it peaked in the rest of the country. And we started ratcheting it down as we went more to remdesivir and we went to the convalescent plasma. Last week, we only used it 3 times. I talked to Dr. Fauci yesterday. As you know, I serve on the National Coronavirus Task Force. He said to me that we still have to leave the door open because with all of these studies, there still has not been randomized controlled trials. Now that said, it is our doctors and our practitioners who are working with our patients. These are people dedicated to the preservation of life. Again, we are all learning as we go, in this crisis. I would also add that the rest of the world is all over the map. France banned it, and then the government in India said it is absolutely essential for them to provide their people with it to protect them from the virus. So again, we have ratcheted down as we've brought more treatments online, and I expect that trend to continue in the future. But our mission was to preserve and protect life.
Mr. Secretary, thank you very much for your commitment. However, I would hope that the VA would respond to the science that is clearly coming from Dr. Fauci rather than some wishful thinking coming from the president. But let's move on to another question. It's very disappointing to me that the VA was using that drug that Dr. Fauci did not endorse. And I've known Dr. Fauci on the committee forever, for at least 30 years. And I would listen to him rather than the president when we're looking for scientific information. I'd like to get to the mental health issue because we know that social isolation poses dangers for the general population, but particularly for the veterans who have suffered with mental illness. Can you tell me what the VA is doing to continue connections with at-risk veterans during this time of stay-home orders? And are you anticipating an increase in mental health services when this pandemic subsides?
Well, we have changed the way we do business when it comes to mental health care. And I think that is the silver lining from this crisis, because we have sent out over 40 million individual communications, not just to veterans, but to families and caregivers. We're unique as a healthcare system in that, like the military, when someone joins, the family joins. And we have expanded our footprint in mental telehealth, I think to the benefit not only of the veterans today, but the benefit of veterans to the future. I will be, Madam Chair, inaugurating our Prevents Task Force recommendations on mental health and suicide prevention on June 14th. That will be the first national roadmap that will fall in line with the question that you just asked about the way of the future when it comes to mental health. I think we will be the first large healthcare organization to have a national conversation to invoke a national conversation on mental health and how we treat it. That also will include a roadmap on homelessness and will also include a roadmap on addiction. That is in line with your thinking, and I know that is in line with the thinking of the chair.
Madam Chair, I believe my time is up. I'm not sure what timing we're using. Shall I?
Your time is expired, Madam Chair. But
Thank you very much, Madam Chair.
Thank you. We'll be doing a second round, so there'll be another opportunity. Thank you so much. And just before we move on to the next question, I'll just note, Mr. Secretary, for the record, that Dr. Fauci said just yesterday on hydroxychloroquine that the scientific data is, and I quote, "The scientific data is really quite evident now about the lack of efficacy." So he's made it very clear where he is on the effectiveness of hydroxychloroquine.
And as I mentioned, I talked to him after he made that statement and relayed his thoughts to him.
Thank you. Next, we have Ms. Roby. You're recognized for 5 minutes.
Thank you, Madam Chair. At a time when we are in the midst of the most serious health pandemic in over a century, the Central Alabama Veterans Healthcare System still has multiple leadership and staff positions that are unfilled. Currently, there is no permanent director. There's a pending start date for a chief of staff. There's no permanent deputy chief of staff, and there are an additional 6 service chief openings with no permanent staff at Cavitts. It remains unacceptable that Cavitts still has so many senior staff openings. I just don't understand how you, Mr. Secretary, can expect to bring about positive change for our veterans' care and the management to the VA employees when you have no permanent leadership to bring about this change. It's especially concerning that after the previous director left in September of 2019, we still do not have a full-time director, and it's almost June. We know that Central Alabama VA has much improvement to make, and the right attention at the highest levels of the Department of Veterans Affairs is warranted, which is not effectively happening now. My office continues to have difficulties in getting answers from CAVIX to even the simplest of questions. In preparation for this hearing, my office reached out to the VA staff here in Washington and directly to CAVIX with questions about staffing vacancies. My Washington office received a fairly prompt response, while my district office has yet to receive an answer from CAVIX and made that request 13 days ago. While I appreciate the response time of the VA staff here in Washington, the staffing vacancy data was readily available because it had been included in a report provided to Congress on May 14th. That report, specific to CAVIX, was required by law due to language that thankfully the chairwoman and I pushed to include in the Appropriations bill last year. And for the members of this committee, we had to put language into law to get the VA to communicate with me specific to CAVIX. As I said repeatedly, it has been difficult, if not impossible, to get prompt responses from your office. Apparently, the only way that we are able to get you to provide information is if this committee requires you to by law. Or if you're scheduled to testify before our committee, the information is nicely delivered right before a hearing. My office has been left in the dark with the COVID-19, mostly in the dark with as it relates to COVID-19 and updates from CAVIX. Since this pandemic began, CAVIX has held only 2 congressional staff briefings, both in April. That seems to be woefully inadequate, especially when it is my understanding that Birmingham, and for those of you who are not familiar with Alabama, it's about an hour and a half north of Montgomery. The Birmingham, Alabama VA has been providing congressional COVID-19 briefings every 2 weeks. I was encouraged to hear that CAVIX would be holding their first congressional COVID-19 briefing in over a month this Friday, May 29th. Well, that was fleeting because that briefing was just postponed yesterday. It was not postponed for a week or 2 weeks. It was postponed for an entire month, meaning it will be 2 months in total since we've heard from CAVIX on COVID-19. Madam Chair, I know you and our colleagues on this committee have continuously heard my pleas and pushed to improve the management and overall care for our veterans in Central and Southeast Alabama. And please know that I will continue to push for answers and actual improvements until my last day serving in Congress. Mr. Secretary, my wish is, and my hope, not for me, but for the veterans that I serve, is that we won't continue to talk about how we hope CAVIX will improve, but that your actions as the top leader in the VA will demonstrate to those veterans the actions, real improvements will demonstrate your commitment to CAVIX. So I'll give you an opportunity to respond to my comments.
Madam Chair, is it, I'm past the time, may I?
No, you can respond. Thank you, Mr. Secretary.
Well, I will say, one of the first visits I made as Secretary was to Central Alabama, both to Montgomery and to Tuskegee. I think I was the first Secretary to ever visit Tuskegee, and very proud of that. I've paid attention to it. We have changed leadership. I believe that the folks in Montgomery and Tuskegee have provided the entire state of Alabama with important services. We have placed many of our employees in Central Alabama at the Bill Nichols State Veterans Home to help the veterans there who were in deep crisis. The staffing issues that you're talking about, and I understand the value of permanence, but those positions are occupied. I have the same issue in my central office, in my office. I have an acting deputy. I have an acting chief of staff. That doesn't mean that the work is not being done. We are in the midst of revamping our entire HR program at VA. I agree with you the first time that you raised this issue, that it was not adequate for the entire country and certainly not adequate for Central Alabama. And as you know, my family lives in North Alabama, so it's a state that I'm in a lot. And we're doing everything we can to make those positions permanent. We have new leadership, as you know, both in Atlanta and in Montgomery. And I think I think that the services have improved across that visit. And I will continue to focus on it because, one, I'm very familiar with the area. And I've heard you, and believe me, the Secretary in general, focus has been to personally move on the leadership issues in your district. And I wish I could say I could snap my fingers and they would all be fixed. But I think it's in a better place than it was when you first raised the issue with me.
I don't know who, Mr. Bishop has the gavel. I would just say to you, Mr. Secretary, where there have been some improvements, the situation is still very dire. And whereas I want nothing more than to celebrate improvements in care for our veterans, we have a long way to go. And it feels like every time we have this conversation that I'm the only one that feels a sense of urgency here. And I just want to see more passion and urgency from your office and dedication to dealing with, we're still one of the worst VAs in the country. And I have been banging my fist for years on this issue. And so, again, I want to celebrate whatever improvements there are to celebrate, but just know we have a very long way to go. And I'm sure Mr. Bishop could comment on that as well. And I yield back. Thank you.
I thank the gentlelady. Let me welcome you, Mr. Secretary. Let me thank you for all of the efforts that you and the team at VA have undertaken to continue services to our veterans under these extreme pandemic conditions, as well as your efforts to keep both the services providers and our veterans safe during the process. But let me ditto and join and associate myself with Ms. Roby's remarks. While she represents Alabama, I represent the West Georgia aspect of CAVIX, and we have some serious concerns, and we continue to raise them, and Ms. Roby's voice is not the only voice that has been raised with those concerns. The delays that have been caused by COVID-19 have caused delays in your systems and your plans across the country, and I assume that the delays also have come in responding to the questions that I raised last time we spoke regarding the VA center that is to be constructed in Columbus, Georgia. And at this point, I'm very, very frustrated that after almost a decade, we're still waiting. And of course, after the contract was let, it was relet. And the site that was selected for a second time is a site that has no public transportation. It's away from the long-established medical campuses that have specialists for our veterans. And of course, it's not very convenient at all. And as I indicated the last time we spoke, and the time before that, we have yet to receive a satisfactory answer as to what went into that decision and whether the proposed location can be changed and can be made more accessible. This has been a process that has been ongoing now for almost a decade. So I'd like for you to comment on that. And of course, I have a second line of questions with regard to the impact that the COVID-19 has had, which caused you to pause all of your in-person compensation and pension examinations. I understand that that was to keep the veterans and the physicians safe during the pandemic. But some of the exams are being completed using the telehealth technology, and file reviews, though, through the, I think you call it the Acceptable Clinical Evidence Initiative. And I understand that you're exploring new exam delivery models, such as a telehybrid model, and the extension of authority to allow the compensation and pension examination providers clinical licenses to cross state lines. I'd like for you to tell me what additional tools you need from Congress to ensure delivery of timely and high-quality CMP exams. With the pause of the CMP exams over the past 2 months, what course of action you will take to address the ballooning backlog, and what are the technological changes VA is looking at in addressing the coverage for elderly patients and other vulnerable populations to ensure the safety of both the patients and the providers. Please address the Columbus, Georgia issue first, please.
I will address Columbus first, and then if you don't mind, let Dr. Lawrence answer the compensation issue. You're right. What's happened in Columbus is not acceptable. I can say that I have the same issue in Mr. McCarthy's district in Bakersfield, California. We are taking a look at the way we acquire and build properties. It is a 19th century system stuck in the 21st century. It's doubly important in your district because I think at the end of this year, Georgia will have the 5th highest number of veterans of any state in the country. I will continue to push, and we'll get you another report as soon as I will start it as soon as I leave. I agree with you. It is unacceptable. And I will, when we can take these masks off, I will promise to come see with my eyes and be with you to look at that site.
Sir, in terms of the compensation and pension exams, CMP exams, very much appreciate your question. We follow the lead of our hospitals, the VHA. They stopped doing these exams on April 2nd for obvious reasons of safety. We told our contractors to stop on April 3rd. You're right, we did some telemedicine, some hybrid, and something called ACE, as you indicate. But you're right, the failure to meet in person, you can only do those things I just described and you described for a limited number of the total. The failure to be able to do in-person compensation and pension exams sets us back as we can't process claims. We're partially awarding claims, we're awarding some of the claims we have, but this is a big deal. We are working with the vendors to get ready to reopen, again, following VHA's lane. You were generous to ask, what do we need? We have a request before you to do 2 things. Allow doctors who do these exams to practice across state lines, and allow non-doctors, essentially nurse practitioners, to do some of these. We think that'll greatly expand our capacity, which will bring down the backlog. I know you're concerned about the backlog, sir. This morning it's 114,000. In November, it was 64,000. We know how to drive it down. We're not proud of this. Our team is embarrassed. We want to open up, get the CMP exams, and get back to that very low number.
Thank you, sir. I think my time has expired. At this time, I recognize Mr. Cartwright.
Thank you, Mr. Bishop. And thank you, Mr. Secretary, for coming today. I listened to your opening statement, and you said that we've lost hundreds of veteran patients to this COVID-19 disease, and in fact, that's what you wrote in your written opening statement as well. Am I correct?
Yes, sir.
With over well, what I have is 1,100 VA patient deaths in my statistic. Was that?
No, sir, it's 700.
It's 700?
Yes, sir. That's 11,000 infections, and about 9,000 of those 11,000, I can get you the exact number, have fully recovered. So right now, we have a total of 1,500 veterans in our 170 hospitals who have.
You said that. Yes, I got that. Okay, so we're here doing oversight, obviously, and this committee's here to be helpful to veterans, their families, and their caregivers and everybody is understandably frightened of this disease and their health prospects during the pandemic. There's been some debate, and I wanted to bring it up with you, about how much authority the VA has over state-run veterans' homes. Now, we're very proud. I'm from Scranton, Pennsylvania, and we have the Gino Murley Veterans Center, which has had no deaths, 0. It's a state-run veterans home in Scranton. But that's not been the case all over the country, and we have to talk about this. Debate about whether state-run veterans homes that receive federal payments and are subject to federal inspections. Mr. Secretary, you've taken the stance that the protection of veterans from infectious spread in those state homes should be left to the states. And my question is, did that work well? My understanding is that there are hundreds of veterans across the country who have died from COVID-19 in state-run veterans' homes. Am I correct in that?
That is true, and I think we account for many of those in our numbers that I will give you.
Okay, so here's where I'm going with that. Might a stronger, more comprehensive, united policy, maybe one that takes into account where our victories have been, like in Scranton, might a stronger, unified response for the 50 states work better for the state home veteran residents where lives were lost?
So I think it's one of the most important questions that will come out of this. And if you would indulge me for a minute, and I will talk about the two separate systems and why Congress did what it did and what we do in relation to
How about 30 seconds?
Okay, real. Congress was very clear in separating us from state veterans' homes in terms of management, operation, and control. In fact, it says it several times in the statute. We provide surveys just as the Joint Commission does for the 6,700 hospitals around the country. I'll give you the example of Massachusetts. In Massachusetts, we delivered a report to the Commonwealth of Massachusetts on January 31st, 52 pages with 7 recommendations, including infection control. The Commonwealth is the certifying authority for that home. We do provide those recommendations. When this hit, I began calling governors. I called your governor, called the governor of Massachusetts, governor of New Jersey, said, what do you need from VA? We're there to provide that bridge between the states and the locality. In your neighboring state, we've come in and taken control of 2 nursing homes. I think there needs to be a debate, a clearer debate, on what the final federal responsibility is for those state veterans' homes.
Okay, we'll talk about that, but I have to move on. I want to talk about testing of VA employees.
Yes.
Mr. Secretary. Now, there's a VHA Directive 1047 issued on April 21 this year. It deals with the All Hazards Emergency Cash Program and has an appendix. It's an opinion from the Office of General Counsel. And subsection F of that opinion says, pursuant to statute, VA has the authority to provide certain health services to its employees, and that includes that VA has the authority to provide medical countermeasures to employees. Now, the VA already provides key immunizations to its own employees who are not veterans and who are not eligible for routine health care from the VHA. Do you agree with the General Counsel's statement of authority that this type of medical countermeasure is both appropriate and legal?
Congressman, yes, we do. We have
Good.
testing available for employees.
Good. And can we agree that testing VA employees who are routinely exposed to COVID-19 patients would provide an infection spread prevention benefit?
We move in lockstep with the science, sir, and CDC guidelines, yes.
Thank you. So as a medical countermeasure to prevent patient-threatening conditions, as described in the General Counsel's opinion, does the VA currently offer testing to its non-veteran employees who are routinely exposed to COVID-19 patients?
We do, sir. Our employees who are symptomatic or who request a test from us are able to get one through us or through their outside health insurance, should they have that, yes.
Well, I'm glad you said that, because here's why I asked. as I say, I'm from northeastern Pennsylvania, and we have a VA medical center there. And that testing was not offered in May or so far it wasn't offered in April or so far in May at the Wilkes-Barre VA Medical Center. Employees there, including those caring for COVID-19 patients, have been required to seek testing elsewhere if they were not veterans themselves, and so ineligible to register with the VA for comprehensive medical care. Here's my question. Were either of you aware of that going on at the Wilkes-Barre VA?
I was not aware of what was going on in Wilkes-Barre.
All right, well,
I will take a look at that.
We need to talk about that.
Yes, sir.
And I'll have more questions in the next round. Yield back.
Thank you, sir. At this time, I'd like to recognize the gentlelady, Ms. Bustos.
All righty, thank you, Mr. Chair. And Secretary Wilkie, I want to thank you and your team for being here with us today. I'm actually going to start off a little bit where Chairwoman Debbie Wasserman Schultz started on the question about PPE. And Matt, if I have any time, I want to go into testing a little bit as well. And you may recall this, Secretary Wilkie, when you were here on March 4th talking with us about your budget request. I asked you about the VA's ability to respond to the coronavirus. So that's going way back to March 4th. At that time, here was what you answered to my question about your preparation. You said, this is your quote, "We trained for epidemics. We began moving on supply chain and preparation really before this became a national issue." That was your quote to me on that date. You assured us at that time that the VA was uniquely prepared among government agencies to respond to the coronavirus, and you testified that your agency had been, quote, "augmenting the supply chain," end quote. So those were the assurances on March 4th. Then let's fast forward a little bit to late April. Dr. Stone, the executive in charge of the Veterans Health Administration, described that your system was facing severe shortages, with some of your hospitals near, quote, end quote, austerity levels of personal protective equipment. So again, you talked about your agency training for epidemics. You began preparation early, yet it was about a month later that your hospitals faced this dire situation. So wondering what the disconnect was in that very, very short amount of time between what you told us as a committee here, subcommittee, and then what Dr. Stone talked about just a short time later.
Well, there isn't a disconnect. What happened in between the time that I testified and the time that Dr. Stone delivered those remarks was that a national emergency was declared, and that the provisions that we made for independent supply chain and equipment was disrupted. We no longer had access to that as things flowed into the national stockpile, and that equipment was spread across the country. I mentioned earlier, I'll do this really fast, I'm looking at ways to prevent that from happening again in the event that this thing boomerangs back on us in the fall. But that is what happened. But I think in the rest of Dr. Stone's remarks, he probably said that we did not fall beyond 2 weeks of supplies in any of our hospitals. We never ran out, because we have the ability to do what they call the Navy cross-deck. There are huge swaths of this country where this virus is not impacted. If you look at North Dallas to the Canadian border to Idaho down to New Mexico, there are very few patients. And we were able to move supplies from those areas into areas that were hotspots, particularly in the northern part of your state, where we also opened up our hospitals to civilians.
So do you have what you need now? I mean, I know you talked a little bit ago about your level of supplies, but you also just mentioned in your response to me about should this, we have a second wave that really kicks off. Yeah. How are you also mentioned the supply chain. So talk about if the numbers do tick up to a much greater level, and the supply chain issues that you mentioned in your own opening remarks, how's this all coming together, and what assurances can you give us, give the veterans, give the employees that you will be ready?
Well, we are marshaling resources and storing them up.
Okay.
at a greater pace than we had back in February, which was right before I testified. I have been also talking to CEOs of large corporations to make sure that as the national emergency subsides, we start getting large numbers of equipment from them, everything from masks to gowns. So that is the plan. I'm establishing depots across the country. It's an old military model. But I have to be honest, and the chair knows this, I said right after I testified and the national emergency was declared that we were not working in optimal conditions. And we had to compensate for that. Thank the Lord, we've had a very, very low incident of infection amongst our employees. Right now, of the 330,000 employees we have, there are 500 active infections. But we don't want to face another situation where I come and tell the chair that it is not optimal. And I think I've been very clear in stating that we don't want to go through that again.
All right, my time's expired. I yield back.
Thank you, Ms. Bustos. Mr. Ryan, you're recognized for 5 minutes.
Thank you, Madam Chair. Mr. Secretary, always good to be with you. Thank you for all your work, and please pass along our regards to all the men and women in the VA who are on the front lines. I appreciate your, let me first associate myself with the Chair's remarks from her comments, and we appreciate you addressing that issue best of your ability. You know, I appreciate your remarks around telemedicine. There are some tectonic shifts happening in the economy right now and in some of our institutions, and I think digital learning, telemedicine, there are going to be some huge shifts. And so we want to continue a conversation with you about how we continue to build out telemedicine with regard to the VA. In addition to what Ms. Bustos was just saying, I represent Youngstown, Ohio. America Makes, the National Innovation Center built around additive manufacturing. I know there's a MOU in the works with the VA and America Makes with regard to 3D printing PPE into the future. So I hope that we can get that worked out as quickly as possible so that when there is a second or third wave, we have already done the legwork and the groundwork to be able to tap into the maker movement in the United States, which could be very helpful in this regard. Two quick questions for you. One is about the DBQs. So I know that the VA reversed policy on processes relating to the applications with disability benefits and the questionnaires. My VSOs back in Ohio, and I think across the country, thought that this simplified the process for a veteran to obtain sufficient medical evidence, and the implementation of these forms were a key part of the reduction of the backlog of claims. And so many of the VSOs see this as a step backwards. Can you just walk me through your logic on this situation and why you did it?
Certainly, sir. I'm glad you asked about this because I think there's a lot of confusion about it. We welcome all evidence from any medical provider that supports a veteran's claim. So that can come in any forms. The public-facing DBQs were victims of fraud and misleading information that for-profit vendors were taking advantage of our veterans. In addition, by virtue of their public face, we could not keep up with the changes. We had to go through the OMB process. It was designed in a period of time when we were very much paper-based. It had essentially been overcome by events, quite frankly. But again, any veteran can provide any medical information. The DBQ was in some ways becoming irrelevant for the situation and was a real source of fraud that we were working on.
And were you working with the VSOs on this, and the VSO, Herm Brewer, and the VSO Association?
Absolutely. We formed a group to consult with them to get their opinions about this. So it's perplexing that after the fact, after we work with them, they hear this. They understood the situation too, and it troubles us to sort of see what has happened with this. And again, the public-facing nature of it prevented us from being able to change it as things were changing. But again, they're all aware They have access to our systems, as you know, with cards that enable to see the veterans' records and the like. So again, we welcome all information from their private providers. That's never been the issue. It's been this form that has been unintentionally, turned into something that's really causing additional problems.
Okay, I just, whatever I can do to be helpful to make sure that we get everybody on the same page here.
Sure, I welcome that. Thank you for the question, and I'll reach out to Herm too.
I know, like many members of Congress, we rely on our VSOs. Those are our boots on the ground, in the foxhole every single day. So I want to just make sure that their voice is being heard in this process. One final quick question here, Mr. Secretary, if you could. With regard to the disability benefit applications, a lot of the older vets, it's pretty good. I like that. I wish I could do that, Mr. Secretary. They find it difficult to use the technology, and they are really comfortable with going to the offices and kind of getting the eyeball to eyeball, and these offices have been closed. What is the process you guys are going to put in place to re-engage a lot of these vets who we may not be connected with them right now?
Sure. Again, we're going to follow VHA's lead in terms of the three-step process to open, using the right protocols and the like, welcoming the least risky veterans in and going to the most risky, using all the different things. So we're going to follow their process. In addition, and here's touch to your first question, sir, we're working closely with the states and counties as they reopen, because as you know, they can serve veterans too. So we want to have multiple ways of access. And finally, of course, we know some veterans will not leave their home regardless of what we do, but they want in-personal service. So we regularly advertise this number, 800-827-1000. They can call us. These are VBA employees, and we can take their application over the phone. So we're very sensitive to this situation, and we will be communicating how we're opening, how we're engaging the public in person.
Okay.
I would say, Mr. Ryan, that I've actually been amazed at the embracing of many of the telehealth changes by older veterans. I'm a computer Neanderthal myself, but we've had so many encounters. I mentioned the hundreds of thousands that we've had, and because more than half of our population is over the age of 65, these aren't young veterans who are doing this. So they're working with it.
Yeah. Thank you, Madam Chair.
Thank you, Mr. Ryan. Okay, Mr. Secretary, I believe we have a few members that want to ask a second round of questions. I appreciate your indulgence. I'll begin by asking you about testing. That's one of the biggest question marks nationwide that we have throughout this public health emergency, is our capacity and access to testing, the confusion around it, the inconsistency of criteria available at testing sites. So I want to just have you walk us through, what are VA's current testing capabilities? Can you tell us how the testing process works? Do you provide consistent access to testing across all VA facilities? Who's eligible to receive a test, under what conditions? What are we doing as far as criteria to test VA employees? Can they get tested even if they're not showing symptoms? I think we need the clerk needs to reset our clock here. How many facilities have rapid testing available on site? What is the turnaround time for those tests? Overall, the theme of my questions are that the feedback that I'm getting from our VSOs, from different types of VA facilities across the country, is that the testing criteria and accessibility and availability of it is quite inconsistent.
Madam Chair, I'm happy to say we do have adequate testing in VA. We have, at this point, tested more than 125,000 veterans, just over 11,000 of whom have been positive. Most of those, as the Secretary referenced earlier, have recovered or in a convalescent status, more than 76%, and we're happy to see that high rate of recovery. Most of our veterans are also able to be monitored at home, and we are seeing a trend that as we have made testing available and as we are able to catch this illness early, that gives veterans and their families and those they encounter a better chance at being able to fight this and being able to succeed in conquering it. We also have testing available for our employees. Any employee who is symptomatic, who is concerned that they have been exposed or requests a test, is able to receive that. To your question of rapid testing, we do have that in 145 facilities. We are aware that there are specific tests that have been under consideration by the FDA for needing higher accuracy. I'm proud to say that in no spaces in VA are we relying solely on those that are under question by the FDA. In most sites, we have multiple forms of testing available, and we typically receive those results for the rapid in a couple of hours and for the standard antigen tests in about 2 days.
Okay, Doctor, I'm really, for the entire time during the pandemic, have gotten reports that we do not have consistent access to testing based on the same criteria all the way across the VA, no matter, I mean, are you confident, and can you go back and provide me with assurance and documentation that in every VISN we have a uniform access to testing, clear criteria across the board that both veterans and employees can understand, and are you promoting, and that you are promoting that access to testing?
Madam Chair, we'd be happy to provide that. And yes, and to those listening today, we would so appreciate this group and those listening helping us carry the message that if there is a veteran concerned about the symptoms they have or needing a test, VA is here for them. We have more than adequate testing supply. We can actually conduct up to 60,000 a week, and we welcome them to come and see us.
Okay, I just think the messaging needs to be made consistent across all the VISNs so that there is a clear understanding about that. And speaking of clear messaging and understanding, Mr. Secretary, I mentioned yesterday in our conversation on the phone that I had a virtual roundtable and have been speaking with various veteran service organizations on an ongoing basis. And I was concerned about that across the board, they raised issues with the disheartening lack of communication from the VA and consultation with the VSOs at the time. I know that you are having regular conversations with the VSOs, but as I mentioned yesterday, their concern is that they aren't being consulted, they're merely being informed. And there's obviously quite a difference between consultation and feedback when you really want to be able to make sure that they explain to you what works best for veterans. And that's been an ongoing issue at the VA. We're having trouble often getting information from you and from your team. It took over a month for us to get the update on your use of hydroxychloroquine and the instructions also that are being sent out to VAs across the country. I realize that you're in a COVID-19 pandemic environment, but I mean, the Secretary of Defense regularly, who is also a member of the task force and is obviously quite busy with dealing with the military's response, holds regular press conferences, is able to communicate more consistently and effectively. So how can you make sure that you have a consistency of VA guidance and policies that are communicated, consult with your constituent groups, particularly the VSOs, and can you commit to more regularly publicly communicating with the public and the VA community?
Well, I'm going to say that's a very interesting observation. Yesterday, I sat down with CBS News. That was the 102nd interview that I've done.
Right. I know there's a difference, Mr. Secretary, between. I know you've done interviews. That's different than having a give and take.
But it's across. I want to say it's across the spectrum. It's MSNBC. It's National Public Radio. Right. It was ABC. I actually raised your concerns with the VSOs yesterday. About 160 representatives on my call, which lasted over an hour. And I mentioned that I had talked to you. And I urged them to use the forum and to use the time to raise the concerns that you raised with me. I'll be brutally honest with you, I can't guess. But I asked them to send to talk. I can't read minds. I don't mean to sound harsh, but I took your concerns to them yesterday and asked for exactly what you just said that they said that they wanted.
Mr. Secretary, just to make sure you understand, I mean, you're requiring the VSOs to submit questions to you a week in advance before you talk with them. And quite frankly, it's a lot more intimidating on a group of 160 other organizations communicating with you to be the one or two that raise the issue that all of them. As someone who's on a call every week with 233 other of my colleagues, you know, it's not the easiest format right now to raise concerns. I can assure you, I had a very large group of VSOs represented and have been they may not have wanted to tell you to your face, but I can assure you that they have expressed a concern to me.
Well, they couldn't see it just like this. Let me ask one other thing. You mentioned the Secretary of Defense. Having been the Undersecretary and Assistant Secretary, there is a dedicated press corps at the Department of Defense. They live there. There are hundreds of them. We don't have that. I do the best that I can, given the fact that the major publications, newspapers in this country, don't have anybody dedicated to VA. It's sort of a catch as catch can, which is why I've done so much radio and television across the spectrum, but particularly with those venues that you would agree that most people on the Republican side or conservatives wouldn't use.
Mr. Secretary, I recognize that you have done TV interviews. That is different than making yourself available and publicly communicating from a platform with a weekly or bi-weekly press conference to provide updates and also to engage in back and forth with more than just one reporter at a time. And then also the concern, I'm certain you're not questioning that I heard this feedback from the VSOs, and others have as well, making sure that you consult, which is different than informing the VSOs, so they have an opportunity to give you feedback and feel like they can inform your decisions is a different approach than you have been taking.
I agree with your observation to the extent that it is a two-way street.
Yes, it is a two-way street, but right now they only feel that the street is going one way. And can you commit that you will make yourself more publicly available rather than one reporter at a time to more broadly update the public about the ongoing response of the VA to the COVID-19 pandemic?
Well, I don't think any VA secretary has ever had that luxury just because of the layout of the way that we are covered. That's why I've had to turn to.
However you might find an opportunity to do that, I'm sure that because we have that you're the largest healthcare system in the country, that there would be response by the press to hearing from you about the impact of the virus on our veterans.
And I know you don't want to continue this, but I also say I've made myself available from I think the most visible platform in the country, the White House press room.
Right, but not consistently, Mr. Secretary.
Well, I don't think any of us have been because of this.
Not consistently. So you won't commit to more regularly making yourself available?
I am committed to communicating in as many venues as I can.
Okay.
My
advice to you publicly is that perhaps you could do so on a more broad-based basis and ensure that the VSOs will also have an opportunity to provide you with feedback that they can give you before decisions are made.
I want them to provide feedback.
Okay. Well, I'm glad that we had a chance for you to confirm that publicly. And if you could give them a forum to do so without requiring them to submit a question a week in advance, that would probably make them feel more like there's a free-flowing
Now, I will also say that
exchange of
I agree
ideas.
with you that logistically that's almost impossible given the conditions we have now. But I will return to the normal process of having the leaders in. And I don't know that they told you that.
I don't know, Mr. Secretary. I don't know why it is necessary to ask them to give you questions a week in advance. I mean, you can certainly.
Well, there were 160 on the phone yesterday.
Right, I understand, but making sure that you can. If the questions come up between the week before you consult, you're on the phone with them or in a. I am doing. There are things happening in real time all the time during this crisis.
I'm doing what I can as much as I can to communicate, and I agree with you that more information is better.
Okay. Well, I would ask you to go back and review how you might be able to make sure that in more real time, prior to your decisions are concluded, that you're getting the kind of feedback that is effective for the constituency group that you represent. Okay, Ms. Bustos, I'm sorry, Judge Carter, who is still with us. Judge Carter, you're recognized for 5 minutes.
Am I ready? It's on black.
Judge Carter, you're recognized for 5 minutes. Do you have any additional questions?
Yeah, I've got one little conversation I'd like to have, and I thank you for the second round. In March, Dr. Stone authorized the granted certified registered nurses anesthetist full practice authority in those states which permitted it or allowed it, and it was to be a temporary authority. I'd like to know when that authority is planned to rescind that authority. I've heard some stories about an anesthesiologist with time on their hands at the VA. And this is important to me because every time I tried a case back in 1984, lasted about 6 or 8 weeks, and I heard everything I ever wanted to hear about the intubation process and the chemical used to do that process, which was used in my case as a murder weapon, and the paralyzing of the system in order to intubate people with the adult gag reflex. So I guess maybe I know too much about anesthesiology because of that case, and being someone who was unfortunate to have adult onset asthma come on in my 50s. I have to worry every time I go under about something like breathing when I come out. And so I want the person there that should an emergency arise, they're going to be able to provide me what I need. And I'm sure the nurse anesthetists are wonderful people, but they're by definition not as skilled as the anesthesiologist. And I think we owe our veterans, if they're going into a situation where they're going under, that they have the very best that we can provide. And so I'd like to know when that will be rescinded, and what metrics did the VA use to determine the full practice authority was warranted, and was it more than just anecdotal evidence?
Judge, I'll answer the second person. We were in an emergency situation. The original estimates that I gave to the chair in the first conversation that we had after the emergency was declared was that we would probably be looking at 200,000 infected veterans. We needed to find as many people as quickly as we could for emergency purposes. Thankfully, we've been able to hire over 10,000 people in the last 5 weeks. On the nurse anesthetists, because of the immediacy of the ventilator issue, we needed as many people who were skilled in the operation of those ventilators as we could find. And we only used the CERNAs in those states, as you pointed out, those states that had already authorized them to a full range of practice. It was an emergency situation. I don't know when that emergency will abate, but that was the parameter of the decision made, and I'll let Dr. McDonald finish.
Sir, to emphasize the Secretary's point, this was bringing us in line with industry in this moment of pandemic in those states that had already enacted this, 17 by law and 12 by executive order. That's 29 states and about 200 million Americans living in areas served by CRNAs with full practice authority. On our teams, and VA, as I mentioned earlier, has long been a leader in team-based care, including anesthesia team-based care. We needed these CRNAs as vital elements of our team to help give us the agility we need to serve veterans well and well across the country. And this is an element of necessary recruitment that we need for our readiness now, and we need for our readiness if indeed there is a future wave of this in the fall.
So do you expect, when do you expect that you'll rescind this temporary order that you've done, or do you expect it to be permanent?
This is temporary, sir, and it actually automatically expires with the end of the national emergency. At that point, we'd like to come back and have a conversation about the way forward.
So that is actually part of the order, that it will end after the national emergency.
With the end of the national emergency, yes, sir.
Okay, thank you for the information.
Thank you. Thank you, Judge Carter. And our last member to ask questions in the second round will be Ms. Bustos. You are recognized for 5 minutes.
Thank you, Madam Chair. As I continue to talk with veterans in our district, we have mostly a rural district in the central, western, and northern part of the state of Illinois. And we have a great goodwill in the city of Peoria. And what they've conveyed to me is that while you're leveraging your virtual outreach, especially during this pandemic, and Mr. Secretary, you went over some of those numbers of how you've grown the telehealth capabilities. What we're learning is that we have many veterans, and especially in rural areas where you don't have high-speed internet, but also many don't even have smartphones or any kind of digital device that would lend itself to being able to have that telehealth interaction where you can actually make eye contact virtually. Wondering, and I know Will Hurd asked this question, I was over voting, so I didn't get to hear the answer to this, but I understand, Mr. Secretary, that you said that you have a program to lend tablets to veterans. Can you talk about how you will institutionalize that? So to the veterans in our area who don't have smartphones or tablets or anything like that, what can I go home and tell them about this system that you have, and then how you will institutionalize that in the VA?
Yes, ma'am. It is part of our general VA outreach to expand our footprint into rural America. We've been distributing, and the chair and the subcommittee provided monies for that. We're sending these tablets out to veterans who are in those rural areas. If they don't have one, please call us and we'll do our best to get them out to them. Call the VA medical center that they use, and we will work to that. I'll have to get back with you on the training because I don't know all of the ins and outs, but it is part of a comprehensive rural outreach that we have. So for your veterans, please call us and we will get in that.
Okay, so it's literally no question on the supplies. You have the supplies you need to be able to get those out. You have the funding.
We are constantly expanding the number of tablets that we purchase.
Okay, all right, very good. Doctor, anything else to add to that?
To follow on to the Secretary, ma'am, yes, this is part of our, as the Secretary mentioned, comprehensive rural health strategy. Telehealth certainly is a piece of this, and those tablets actually come equipped with internet access so that these are ready-made devices to enable veterans to succeed in their care and engage with us. Additionally, under the Secretary's leadership, we've engaged in a number of public-private partnerships, including with the Rural Broadband Association, to bring telehealth sites to rural areas and also offset the otherwise that would be cost of engaging in telehealth visits. So T-Mobile, Sprint, TracFone, Verizon actually waive the data fees when veterans are engaging with us on a video visit. Additionally, though, the in-person part of rural care provision is important as well. Our clinical resource hubs deliver telehealth. They also send providers to rural areas to engage veterans where they are as a necessary piece of this. And of course, that's supplemented by our community care engagement and availability in those areas.
And do you see any impediments to this rural health program as we have this conversation right now as far as getting the tablets out? Whether there's training that can take place or any issues with that, but any impediments right now as we have this conversation?
We don't see any, ma'am. And as the Secretary said, we're looking to drastically expand this and already have during the pandemic. This started long before this, but we've drastically expanded it now. And we're thankful for those partnerships, for instance, from Apple with iPads, who have prioritized us in their supply chain in order to get this distribution done.
Okay, that's great. I've got a minute left, so I'm going to squeeze in this last question. Mr. Secretary, you mentioned at the start of your remarks your surge hiring of about 10,000 employees. Can you talk about what kind of employees, mental health, just kind of what is the layout, geographic? Can you go into a little bit about what those 10,000 employees are doing, their jobs, where they are, et cetera?
We have cut many corners. We have used emergency hiring authorities, but we've also eliminated many of the bureaucratic barriers to hiring. About of those 10,000, about 3,000 are nurses, 700 are doctors. We've told them that if they want to join us, they can stay in their homes, their home regions. And so I don't have the breakdown across the country, but it's a significant number. Do you have any?
Yes, and just want to emphasize, as the Secretary said, that we've hired more than 11,000. Earlier this month, it was actually Nurses Week, and we are very proud to have brought on thousands of nurses. Hundreds of doctors, as the Secretary mentioned, respiratory therapists, the CRNAs we were mentioning earlier. These high-priority roles that we need to deliver healthcare in the team-based way that we know is so effective for this illness and for the chronic conditions that many of our veterans face. And we are planning to continue that aggressive hiring as we move forward through the summer and into the fall to maintain our readiness stance and make sure that we're ready for what comes.
All right, very good. My time's out. I yield back. Thank you very much.
Thank you, Ms. Bustos. That concludes this morning's hearing. Mr. Secretary, Mr. Secretary, I gave you an advanced degree. Dr. Lawrence, Mr. Michalski, Dr. McDonald, thank you for appearing at today's hearing. We clearly have covered a lot of ground, and we have a lot to do in front of us to continue the response to protect our veterans and the employees that work for the VA against the coronavirus. I look forward to continuing to work with you all to do that, to continuing our ongoing conversations, which have been incredibly helpful and informative and have given us a real opportunity to have the kind of give and take necessary in the midst of an ongoing crisis. Thank you, and on behalf of our committee, and please send our appreciation to all of those that are working so hard to protect our veterans. With that, the subcommittee stands adjourned.
Click the minutes.